30 million people around the world have been infected with COVID-19.
581, the majority still in China on January.
And the US has become the country with the most coronavirus cases worldwide.
That COVID-19 can be characterized as a pandemic.
Just stay at home.
Originating in Wuhan, China, the first COVID-19 case was reported to the WHO country office in China on 31 December 2019. On 11 March 2020, the Director General of the World Health Organization (WHO) declared coronavirus disease 2019 outbreak a pandemic caused by severe acute respiratory syndrome coronavirus 2, which is SARS-CoV-2 infection. As of 29 March 2020, COVID-19 has been recognized in over 200 countries, areas, and territories, with a total of over 575,000 confirmed cases and over 26,000 deaths. The most common symptoms of coronavirus disease are fever, tiredness, dry cough, and shortness of breath. Similar to SARS-CoV and the Middle East Respiratory Syndrome MERS-CoV virus, SARS-CoV-2 is a zoonotic virus which can spread from non-human animals to human. The asymptomatic incubation period of the virus is estimated to be between 2 and 12 days. However, up to 24 days incubation period was reported in some studies. More than 80% of cases are mild and recover from the disease without needing special treatment. However, around 50% of cases are categorized as severely ill and the remaining 5% are categorized as critically ill. In severe and critical cases, acute respiratory disease can lead to pneumonia, kidney failure, and even death. The mild COVID-19 cases do not require specific care, and usually asymptomatic treatment and home isolation are enough. Oxygen therapy is the major intervention for patients with severe cases. Critical cases management, on the other hand, is case dependent and will usually need intensive care. Human-to-human transmission is now believed to be mainly via saliva-associated respiratory droplets and contact transmission. To date, real-time reverse transcription polymerase chain reaction (RT-PCR) test is utilized for the qualitative detection of nucleic acid from SARS-CoV-2 in upper and lower respiratory specimens. They are obtained through nasopharyngeal or oropharyngeal swabs. Moreover, viral RNA has been also isolated from the plasma of some patients. During the course of this pandemic, alteration to dental treatment should be considered to maintain a healthy environment for the patients and the dental team. SARS-CoV-2 has been isolated from the saliva of COVID-19 patients. Moreover, salivary gland epithelial cells can potentially be affected by SARS-CoV and become a major source of the virus in saliva. Despite the large-scale community transmission of COVID-19 in China during the epidemic, demand for urgent dental treatment decreased by only 38%. This shows that the public need for urgent dental care even during the pandemic will always be essential. Closing dental practice during the pandemic can reduce the number of affected individuals, but will increase the suffering of the individuals in need of urgent dental care and also increase the burden on hospital emergency department. The calls for the creation of standard guidelines for dental care provision during the worldwide spread of pandemic and local epidemic outbreaks. The aim of this topic is to develop a guidelines for dental patients management during and after the COVID-19 pandemic. To develop guidelines for dental care provision during the pandemic, the following factors should be considered. First, the incubation period of the virus is believed to be up to 14 days, and transmission from asymptomatic COVID-19 carriers are possible. Second, aerosol and fomic transmission of SARS-CoV-2 is possible. Third, COVID-19 recurrency might be possible, and some virus strains can be present in saliva for as long as 29 days. And fourth, some confirmed COVID-19 carriers might need urgent dental care at some point. That necessitates, first, screening every asymptomatic patient meticulously. Second, considering every patient as a potential asymptomatic COVID-19 carrier. Third, considering recently recovered patients as potential virus carriers for at least 30 days after the recovery confirmation by a laboratory test. Fourth, identifying the urgent need of the patient and focusing on managing it with minimally invasive procedures. 5. Categorizing dental treatment according to the urgency of the required treatment, risk and benefit associated with each treatment. 6. Identifying the required dental treatment for each patient, the risk and benefit associated with that treatment. And the last one, using contact and airborne precautions including proper aerosol generating procedures, personal protective equipment, PPE for every procedure.
From those considerations and necessities stated by Hazika, patients' need for dental treatment can be categorized based on their probability as infected person or carriers of COVID-19. As we can see in the flowchart that indicates the overview of dental patient screening and categorization method, when screening is done, there will be two outcomes, whether it is confirmed COVID-19 case or it is unconfirmed case. If it is unconfirmed case, they will be classified into two classes, which is asymptomatic unsuspected, where the treatment for them is category A, B, and C, while the other one class is symptomatic suspected, which the treatment categorized for them is A. As for confirmed COVID-19 case, it will then categorize as active disease or recovered patient. Active disease consists of stable and unstable condition, with both of them require coordination with primary physician. Category treatment for unstable active disease is A, while for stable active disease is category A and B. As for recovered patient, after at least 30 days recovery confirmation laboratory test, will determine whether the patient has free from COVID-19 virus or still not recover completely and has potential as virus carrier. If the lab test confirms that the patient is completely recovered, the patient will be able to receive full dental treatment, and if the patient is not confirmed as completely recovered, will treat in category A and B. All these categories stated will be discussed later in treatment categorization. So, as for patient screening, firstly, telescreening is strongly advised. Telescreening means a telephone survey conducted to check on patient's condition. Secondly, patients should be screened for any symptom of COVID-19, any recent contact with confirmed COVID-19 patient, and any travel history to recent disease epicenter. Third, dental treatment should only be considered for active and recently recovered confirmed cases after coordination with primary physician. Fourth, evaluate meticulously patient's disease history and current stage. Fifth, if possible, postpone the treatment of any suspected or confirmed COVID-19 patient's treatment, or if it can be delayed, perform the treatment in an airborne infection isolation rooms or negative pressure rooms, ideally at a hospital setting. Based on the screening, patient can be divided into 5 groups, which is Group A for asymptomatic and unsuspected unconfirmed COVID-19 case, Group B for symptomatic and or suspected unconfirmed COVID-19 case, Group C for stable confirmed COVID-19 case, Group D for unstable confirmed COVID-19 case, and Group E for recovered confirmed COVID-19 case. As what stated on the journal, the current COVID-19 case are considered stable if the case is mild and no hospitalization or oxygen therapy required. It will become unstable when it involves severe and critical case. Patient is considered as confirmed recovered when the patient has been asymptomatic for at least 30 days after the last negative lab test. So, as for dental treatment categorization, it can be classified based on the severity of the cases and the degree of procedures, invasiveness, and risk. There are 5 categories of dental treatment, as you can see in the mind map. Also, we will go through one by one about the conditions of treatment for each category. So, for the first one is category A, which refers to the emergency management of life-threatening conditions, such as unstable maxillofacial fractures that can compromise the patient's airways, diffuse soft tissue bacterial infection with intraoral or extraoral swelling that can compromise the patient's airways, and uncontrolled postoperative bleeding. Category B is referred to urgent conditions that can be managed with minimally invasive procedures and without aerosol generation. The conditions of Category B consist of severe dental pain from pulpal inflammations that require tooth extraction or from fractured vital tooth, dental trauma with avulsion or luxation, surgical postoperative osteitis or dry socket, pericoronitis or third molar pain, stable maxillofacial fractures that require no interventions, localized dental or periodontal abscess, and fracture or defective fixed orthodontic appliance causing soft tissue laceration. All these conditions in Category B can be managed without aerosol generation. Then, we move to Category C, which is urgent conditions that need to be managed with invasive and or aerosol generating procedures. The conditions involve severe dental pain from pulpal inflammation or fractured vital tooth that need to be managed with aerosol generating procedures, dental trauma with avulsion or luxation that need invasive or aerosol generating procedures, debone fixed prosthesis, cleaning and temporary cementation, removable dentures adjustment for radiation or oncology patients, fractured or defective fixed prosthesis causing soft tissue injury and acute periodontal disease. Category D referred to non-urgent procedures where the condition includes removable dentures, adjustment or repair, asymptomatic fracture or defective restoration, asymptomatic fracture or defective fixed prosthesis, asymptomatic fracture or defective orthodontic appliance, and chronic periodontal disease. And the last category, E, referred to elective. The conditions that can be considered as elective are including initial or periodic oral examination and recall visits, aesthetic dental procedures, restorative treatment of asymptomatic teeth, extraction of asymptomatic teeth, orthodontic procedures other than those in category B and C, routine dental cleaning and preventive therapies, replacement of missing tooth or teeth with fixed or removable prosthesis, and dental implant surgery. There are several things to consider for treatment to be carried out. The first thing, intraoral imaging should be restricted and extraoral radiograph should be utilized to reduce the excessive salivation and gag reflex associated with intraoral radiographs. Intraoral refer to X-ray film is inside the mouth, while extraoral refer to X-ray film is outside the mouth. Secondly, by using 0.23% of povidone iodine mouthwash for at least 15 seconds before the procedure can reduce the viral load in the patient's saliva. Third, disposable and single-use instruments and devices should be used whenever possible to reduce the cross-infection risk. 4. Rubber dam should be used whenever possible as this will significantly reduce the spread of microorganisms. 5th, the dental treatment should be as minimally invasive as possible. And 6th, aerosol generating procedures should be avoided whenever possible. The last thing is, whenever pharmacologic management of pain is required, ibuprofen should be avoided in suspected and confirmed COVID-19 cases. We can conclude that, in fact, there are no universal guidelines available for dental care provision during the times of any epidemic, pandemic, national, or global disaster. That's why, due to that lack of a standard, dental care provision has completely stopped or significantly decreased in several affected countries. This is bad because it is not only increasing the affected population suffering, but will also enhance the burden on hospitals' emergency departments that are already struggled with the pandemic. Lack of guidelines can also increase the nosocomial COVID-19 spread through dental healthcare facilities. Due to the possibility of COVID-19 recusancy and the fact that some viruses can be present in saliva for as long as 29 days after recovery of the patient, the management of recently recovered COVID-19 patients was also considered in these guidelines to help in reducing and preventing new outbreaks. These developed guidelines are general, and the final decision will always be provided through the practitioner's judgment. This guideline is hoped will help in the management of dental care around the world during this COVID-19 pandemic and provide a solid base for further healthcare guidelines development. That's all from us. Thank you.